Bismillahirrahmanirrahim. Now we'll start the next session. It's about emergency medicine. I'd like to welcome Dr. Marzuq Azmi, consultant immunologist, and Dr. Mazen Thomas. Dr. Marzuq will introduce our speakers. Please come, Dr. Marzuq. Thanks.
Assalamu alaikum. Good evening. First of all, I'm not a immunologist. I'm a pediatric emergency specialist. We would like to welcome our next guest speaker, Dr. Anna Janvis from Canada. Dr. Janvis is a professor in the Department of Pediatrics at the University of Toronto. She is known for her interest in pediatric life support procedures, clinical outcomes, and medical education at all levels. Dr. Janvis contributed in the evolution of the Canadian emergency medicine and pediatric emergency medicine specialties. Also, she contributed in the development of the emergency medical services, pediatric life support training, and pediatric Canadian triage and acuity scale PCTAS clinical treatment plans. So please welcome with me Dr. Janvis.
Thank you very much for that generous introduction, and thank you for having me. I love coming here. You've already given my disclosures that I'm talking about a subject near and dear to my heart, because back in the 1970s, when we were saying we needed to have a different triage system in emergency rather than seeing first come, first serve, it was a fight. The public wanted to be seen as in order of their arrival, and we were having some disasters of adults and children collapsing in the waiting room. So I forwarded a handout, and all my disclosures are on it. No one pays me for doing those things, so there's no financial conflict. I wanted to give a brief history of medical triage and a selected triage tools, because there are many tools available, and you have to understand your needs very carefully before you introduce one or choose one for your own setting. I want you to learn why accurate measurement of vital signs is critical in the management of any child who has a serious or significant illness. I want you to be aware of some of the weaknesses and the challenges in analyzing the vital sign measurements you make, and the critical importance of the right tool, not just for your institution, but who is the patient? Is the patient in emergency? Is the patient on a general ward? Is the patient in a clinic? So believe it or not, there are different tools for where you're managing the child. Now, how and when did medical triage start? And it started with Napoleon. And until Napoleon got into his egomaniac ruler of the world mode, he was very successful. All the things we talk about now of professional healthcare workers looking after themselves, the way pilots do, that we need to eat and rest and take care of ourselves to be efficient, that we need breaks from the pressure of work, we need a life outside of medicine. All these things he knew, and although his army was chiefly made up of mercenaries, he was successful for the first many, many years because he fed and watered his troops. He understood hand washing and basic hygiene before the germ theory was well written out, because he realized with his barons, Larry to your left and Percy to your right, he realized that if he moved camp every 3 days, he did not have any dysentery breaking out. This man was a scientist, although he was not in healthcare. And he developed a triage system. These barons designed the first ambulances. And if you ever want to find out about this and how it evolved, you should read some of their biographies. Now, triage systems, as Napoleon developed them, were to take care of his troops and to get people back to the battlefield, his soldiers, as soon as possible. Therefore, he wanted his doctors to treat the least injured first, so they wouldn't get infections and need amputations. He wanted them hale and hearty so they could work. We use this in multiple trauma or wartime zones. They have, the army and military have different triage systems, and I'll tell you I'm not discussing those today. The Manchester triage system in Great Britain was the first 5-level system. Australia and New Zealand chose a 5-level system. Canada, with the Canadian triage and assessments acuity scale and the pediatric scale, modified these. And the World Health Organization emergency triage, assessment and treatment scale, which I'm going to mention a little at the end, is for poorly resourced areas. And it emphasizes the need, when you have masses of patients, of starting treatment as soon as you recognize they have a problem. There are triage settings, pre-hospital settings, mass casualty. They're inpatients. The Australians have a rapid response or early warning system. Canada has one. And the poorly resourced one from Malawi is fantastic, and I'm going to mention it. Now, why vital signs? Why vital signs? Because children compensate until they're about to have an arrest. The blood pressure doesn't drop till the end, no matter what the cause of the problem. They're in different sizes and shapes. And triage is not just for pediatric specialists and people who are well acquainted with children. They're also for healthcare providers, be they nurses, paramedics, doctors, others, who may not be as well educated in evaluation of children. And then there are all the developmental issues and how children can either exaggerate their pain by screaming too much when they're not that badly hurt, or going very, very quiet when they're about to arrest. So these are things that make them different. Everything varies. In pediatrics, most illness is benign. We calculate that only around 1% of children get admitted to sick kids in the Greater Toronto area. It's only around 1% because the vast majority of children are treated as outpatients. You get quite numb when you're seeing 200, 250 patients a day, and you know you're only going to admit a small handful. So sometimes you overlook early signs of critical illness, and that's why we have vital signs. Right? The other challenge is the complaints seem the same. The mother says he's not acting right, or he feels warm. Do you have this problem here that not everybody takes the temperature, right? So he feels warm. How do you interpret that? Sometimes they vomit. Some children, if you scream at them, they vomit. They don't want to go to school, they vomit. So that one's really a challenge. Then there's the good old cough and cold and runny nose. So these are all challenges. And yet, those with life-threatening illness, it evolves very rapidly, like meningococcemia or pneumococcal sepsis. So this was our first version, and it was the sickest patients get treated first. Triage staff have to be fast and accurate in their decision making, and they are not asked to make the final diagnosis. They are not to be afraid to say, this child has signals of serious illness, I want him or her in a room, I want a doctor to assess this patient. They're not making the diagnosis and they're not predicting admissions. They're only prioritizing the order people are seen in. Treatment should start in triage. Some of our worst complaints from families are children who have been screaming with earache. Now, the child who is very quiet because they're septic, or the child who has meningitis, has to be seen first. But our triage staff are empowered to give pain relief, ice and elevation for injuries. As long as families feel treatment starts, you limit the morbidity for the illness and you decrease your complaints. Only those who are bosses understand complaints. They take up a lot of your time and energy, and none of us like to deal with them. Things change, so there have to be scheduled reassessments. Now, the system that we have in place is that each child should be seen by a professional. When we say seen, that is with the critical look and 1 or 2 questions within 10 minutes of arrival. And the critical look, I'm going to take you over. We then go to the history. What's your little one's name? Why are you here tonight? Obviously, if they say, my child has sickle cell and he had a temperature at home, that's a different child than if he's had a cold and a fever for 3 days, and I think something's wrong, but the child doesn't have any underlying immune deficiency. We then go to the vital signs, and you make a decision. And we expect our triage nurses to make most decisions in 30 seconds, and it can be done. The critical look is the same as pediatric assessment triangle from the American Academy Advanced Life Support course. It's just, what does this person look like? Are they gray? Do they look at me in the face? Or are they glazed in the eyes? Are they struggling to breathe? Or am I not certain they're breathing, they're so quiet? What's their color? So that's just one look. And really critically ill children, you take one look and they don't stay at triage. Within 10 seconds, they're heading for a treatment area. That would include someone who is actively bleeding, arterial bleed, or someone with meningococcemia, right? Someone who's having active convulsive motions, right? Those don't stay for full triage. And we do not ask the nurse to go through all of these history points at triage before making decisions, but we do ask it's an experienced nurse who knows which are the critical questions for the child presenting. I will explain that a bit. As soon as she has an indication that something isn't right, we ask for a triage decision, right? Not for the complete history. So now, what do I mean? If someone comes in with a swollen tongue like that, if this is part of an allergic reaction, you expect immediate action on the part of the nurse. We do have EpiPens at triage, right? So this child inadvertently bit into a peanut and they're allergic to peanuts, for instance. On the other hand, if she says, well, hello, what's happened to your tongue? And the mother says he has a hemangioma in there. That's not a problem today. She has time to breathe. See why the history is sometimes important. anyone who has that kind of purpura, you shouldn't be undressing the child at triage. You should be, you know, masking the mother and getting them into an isolation unit. So level ones, most of the time, take 5 seconds, and an experienced triage person knows what to do. Now, these are emergent things. This little one I did see myself with the S, or figure of 8 fracture there, came off a monkey bar. And she said, I can't feel my fingers. Now, folks, that is an emergency, and something needs to be done to relieve this situation pretty quickly, right? If they are badly dehydrated, that's emergent. So sometimes the nurse decides she's not doing anything else. She calls it a level 2, and the child goes straight in, and the rest of the assessment takes place in a treatment area. If it's not that obvious, the child isn't that sick, we move on to vital signs. And I have put down 3 things at the top that we do rely on heavily in our emergency system: the heart rate and capillary refill. If the refill is 6 seconds, I don't want her doing a blood pressure. I want her calling for the nurse in charge to move that patient to treatment. To treatment, folks, right away. Respiratory rate and effort, and it's both together. If someone has been having bronchiolitis, as happens with those who return, and the mother says, this is getting worse, and he's really tired, and he's had bronchiolitis for 3 days, and we were here yesterday, and they sent us home, and the child's respiratory rate is only 20, and bronchiolitis, I'm calling in the younger kids under 2 years of age, that kid is probably so tired, they're already stepping off the cliff into respiratory failure. They're going to go apneic on you. So it doesn't go any further. And we do like temperatures. Now, depending on the presentation, the other things will be done. They had a seizure at home, I want a glucose, right? If they're acting funny, you need a glucose. If they're in pain, you want a pain score. Now, the challenges are people take vital signs differently, and I urge you to know all the way the nurses in your unit take heart rates, respiratory rates, okay? Then the next thing is, what list of normals do you use for age? And has anyone in the Gulf states gone and measured healthy children or children in emergency departments or inpatients in large numbers to see what the normal graphs are for your children in your setting? Because I recommend this study. They have plotted graphs, and they found that there are great differences between children who are hospitalized, the normals, with those who are healthy at school, with those who are in outpatient offices. So know what you're using, and whatever you do, if you're using a chart, everyone working in that atmosphere, that environment has to use the same chart, okay? So, equipment fails, training isn't up to snuff, people use different volumes. Now, why are the vital signs important? These are friends of mine, and I have permission to use it. The father doesn't look too happy either because this kid was sick, right? So the group 3s would be high fever, like this child, had otitis, put on amoxicillin, develops this rash, and the nurse said the kid didn't smile, the kid was fussy, temperature was 40, pulse 120, and that was a rash I showed you. You need a nurse who knows what she's doing, because could it be infectious? We had a measles outbreak last year, okay? I hope she knows that, what a measles rash looks like. And that was a little one 2 weeks later. She's a gorgeous child, and daddy was smiling as well. 4, less urgent. 5 non-urgent. Believe it or not, we have people who come in because they're trying to see a specialist. Or the kid has pinworms. Well, if it's winter time with bronchiolitis, we really recommend they can either wait 6 hours or they can go to their local clinic tomorrow. Okay? So, critical look, that's what we do. I want to tell you that we use the same system for the paramedics and transport teams. So we can talk to each other and we know what's coming in. And it's been very helpful to have everyone in the system using the same system and the same charts. Now I mention you know what you want because there are no rapid response systems, and they are those for well-resourced centers and those for less resource centers. This is what I mean by triage must fit, the tool must fit your circumstance. The one we developed had all these readings, right? And it has been wonderful because since the system's put in place and they are on the computer, it's computerized, an alarm will go off if the nurse is putting in the results and it shows that this child is getting to a critical zone. The intensive care people have a team, the rapid response team, that will come and assess the patient. And with this, we have reduced our unexpected cardiac arrests and code blues in the hospital. We've gotten them down to 25% of what they were. So that people are transferred to higher levels of care while they are still compensating. Right? Early signs. This system was introduced into a community hospital that has almost 100,000 people visit the emergency every year, adults and children. They have 8,000 deliveries a year. They are very busy. And they put the same system on the pediatric ward, and the stat calls for the pediatricians on call went down from 22 approximately per 1,000 patient days to 5 per patient, 1,000 patient days. So that children were seen before they crashed. And this is very important in a setting that is not as well staffed as a teaching hospital. All right? So these things work, and they call it triage, but it's a different tool. And in Malawi, I love this. I just love it. I am going to take it to the Caribbean next time I go down. My brother's in public health. This hospital was so poorly staffed, it still is, that sometimes the nurse, the qualified nurse, has 100 patients to look after at night. Well, they're lucky if they get one set of vital signs done after emergency. And in the emergency department, they use the World Health Organization triage system, right? So they found that they could train high school graduates who were literate in English and the common dialect of the area as vital sign assistants. I was discussing this with the educators at Sick Kids, and they were horrified that anyone was proud of the name VSA, which means to us vital signs absent. Anyway, these vital sign assistants were recruited and trained, and it's only a 2-week training. And what they measure is only really a few things, right? Because what they measure is heart rate, respiratory rate, oxygen saturation, and temperature. And they start at one end of the ward and they go around as often as they can. And they have a chart of normals. And anyone who scores high, they go and get the nurse. It might be only one nurse for the ward, or the medical student, or the registrar on duty. And the death rates fell from 9.3 to 6.9 with no change in professional staff or numbers. So I just say to you, triage works, vital signs are critical, But when we say vital signs, be very careful that everyone taking them knows how to take them and that they use the same standards. So that's just a quick overview. And I did forward to the organizers the reading list for anyone who'd like to research this a little more.
Thank you, Dr. Jarvis. We'll proceed. Before proceeding to the next topic, any question for Dr. Jarvis? We have questions here.
Thank you for the presentation. Would you let us know how we can access the electronic Pew system?
Absolutely. Christopher Parcheron at Sick Kids Emerge, or Aphrodite, who is in the intensive care. Yeah, absolutely. You ask them about it.
Is there any cost associated with it?
Well, let me tell you that Dr. Parcheron was really intrigued. This was his personal research interest on mistakes made when both staff and trainees were exhausted. And he has worked on this a lot. And then he was intrigued by children who were rested on wards and reviewing their they got transferred to intensive care. And when he reviewed their charts, it became apparent that the children had been deteriorating for at least some hours, many of them for a minimum of 24 hours, and people hadn't recognized it. So he's published around 10 articles on these issues, and I do, Christopher Parcheron, I do recommend it.
Your questions? Okay.
And just to add to that, in our emergency, we have computerized triage. The nurse can override it, but we have like the septic pathway, right? So if certain things come up, an alarm goes, alert may be septic child. And then that child goes on the septic treatment, right? Which is treatment by time, because the outcomes are better. But that's through the emergency. Okay, Jason Fisher.
Okay, Dr. Jarvis, you can go to the
So we move to the next one.
next topic. Yeah.
Change for me, please.